Thank you very much, Dr. Vineet and Dr. Surajit, for the excellent presentation. Dr. Vineet, do you have something to say about this?
Will you change your...
So you have a valid question that remifentanil may not be available in Shivsagar. Even now it's not available in Gurgaon. But the thing is, we are talking about a patient and we are discussing about pros and cons. So we are talking about a standard condition. I may be working at Shivsagar, or you may be working at Gurgaon, or both of us working in a Gulf country. We will be having the similar standardized condition. In that case, we are discussing this scenario. So that remifentanil is available, not available at your place, available is not my place, is not the question raised. The other thing you said, single shot spinal, atraumatic spinal pricking will not cause the hematoma. Who knows before pricking the patient that you will be having a single prick? It is only after single prick you come to know that you will be giving the second prick or third prick or fourth prick, or you will be changing your anesthetist. Who will be responsible if you gave 2 pricks and after that you change your anesthetist and the second person comes and he also pokes 2 times and then they call the third person to give the GA?
That'll be really
Okay.
You want to conclude the thing?
The anesthesia for HELLP syndrome will be tricky because, again, the choice you have to make depends on various factors. There are no specific guidelines mentioning yes or no for both GA or spinal. We have to make a wise decision considering all these factors, like what Surajit had aptly rounded, like considering the other coagulation factors, of course where you are, the level of medico-legal litigations you can face if the patient lands up in a complication. I mean, if you tell him that you have had you have HELLP syndrome and you've given spinal, you can't defend it in the court of law again. So taking all these factors into consideration, I think you should make a choice, because again, guidelines will just give you some directions to follow. So you need to make a discrete choice yourself.
And Surajit, platelets, it's just not hematoma. Okay. Platelets is just not the numbers, it's the quality is also equally important. Yeah. It has been seen that you can actually have no spontaneous bleeding till your platelet count drops to 10,000. So you can actually have 10,000, 20,000 platelets, which are good enough. Okay. Second thing is that you need to know what's going on in the pathology. Okay. If that HELLP syndrome patient is actually bleeding elsewhere, okay, they will be consuming the platelets. You're going to have a surgery, okay, she's going to consume platelets. So unless you actually have facility to actually provide that platelets, I wouldn't go for a spinal. So even if you're in Shivsagar, okay, if you do not have a facility for giving platelets, I won't touch the patient with a spinal. And second thing is, your backup is always a GA. Okay. So you cannot say that you are going to actually say that the subarachnoid block is the only thing. You will have to explain to the patient that I can fail. I may be the best excellent anesthetist who has done millions of spinals, but it can still fail. And that she might actually still need a GA. Okay.
So that's point, good point, sir. And what I also included, actually I have included, but because time constraint I have deleted the slide. So in community health center, the patient comes like this. There is a severe PIS HELLP syndrome and we do not have laboratory backup. Now you have to do the surgery, otherwise the baby will die. You have to do the surgery. So what we do, we take a test tube and I'll put that is 5 ml of blood, and if it clots in 20 minutes, then you can go for spinal anesthesia. If not, then you have to shift the patient to higher center. Even you cannot do the surgery in general anesthesia also. So this point actually I have included, but later on I'll delete it.
It is actually important that these are difficult situation places, especially people who are working in rural health centers, remote areas. I mean, these are difficult decisions. Okay. So this last comment.
I have one question to all the 3 panelists. Suppose, as Pallavi Madam has raised this situation, which appears very difficult for general anesthesia, is it possible, as one of my colleagues has done in a combination, that so count was low, we transfuse the patient with the platelets just to raise this count, and then administered spinal anesthesia and did the case. What is your take on that?
Yeah, I was just going to make a similar comment. We have had 2 patients where we gave platelets and gave the patient spinal once the counts came up. And there are references of platelet counts of even 20,000 being given spinal, and he rightfully said. So that can be a chance. But I feel
it is about quality of platelets. Patients who had 20,000 probably had very good quality platelets.
Exactly.
Okay, you can have even 1 lakh platelet counts, but if they do not talk to each other.
Yeah, so transfusion of platelets and give the spinal if at all.
Just to make yourself medically safe.
Yeah, that's fine. What is saying, I know they're not hearing, was saying it's about quality of platelets. 20,000, very good, yes. You can have 100,000 platelets. If they not stick to each other, they don't talk to each other, they can still have a hematoma. Yeah.
Sir. Hello. Dr. Satish, you raised a good option that you can transfuse the platelet and then you can go ahead with spinal anesthesia. It's okay. But do you have the time in emergency to transfuse 2 units or 3 units of platelets, to arrange them, then to transfuse them, and after giving spinal? No, you don't have the time. You have to take decision then and there. So you don't have the, so this option, yes, of course, if you have the time, you can always transfuse the platelet and you can go ahead with your choice of decision.
Hello. My question. There are too many things, please. I think.
During surgery, if they operated, there is no reason why simple speed. What is an accident? What is telling that we are discussing a problem of surgeon? No, in anesthesia.
No, that's nothing to do now. No, their patient bleeds, it is our problem. Okay, simple as that. When your patient is under anesthesia, it's anesthesia problem. You deal with it. It is not blaming the surgeon. The patient needs a surgery. Okay, it's your responsibility to actually arrange things. Okay, yeah, very good point. Okay.
My question to Dr.
Last comment.
Vinit Gupta. Sir, how is your experience with labetalol and hydralazine for PIH with HELLP syndrome?
Sorry, this is not a PIH question. Sorry. No, this is not the debate for PIH. Okay, this was for the spinal versus
the intracranial
hemorrhage. You can put this question in the thing. This is not the question for that. Okay, let's go for coffee break, please.